So with that, we'll head into our first lightning talk, and that will be presented by Danya Fast on pharmacotherapies, futures, and the overdose crisis. So I'll pass it off to her.
Great. Oh, can everyone hear me? Yeah, okay, fantastic. All right. Good morning, everyone. I'm Danya Fast. I'm a medical anthropologist who's been doing research with street entrenched youth who use drugs in Greater Vancouver since 2008. And today I'm presenting some of my team's findings from some recent research that we've done. Most of our research takes place on the traditional unceded and occupied lands of the Musqueam, Squamish, and Tsleil-Waututh. Some of our research was also conducted on the lands of the Syilx Okanagan and the Lheidli T'enneh. Recently, there have been numerous efforts to improve youth's access to evidence-based treatment, including opioid agonist therapies, or OAT. And of course, a variety of psychopharmaceuticals are prescribed to youth who use drugs to help them manage concurrent mental health issues. In the context of the current overdose crisis and COVID-19, the landscape of services, supports, and pharmacotherapies available to youth is constantly evolving. My research examines how youth themselves understand, experience, and navigate the shifting landscape of care across time. Today, I'm drawing from 3 sources of qualitative data: longitudinal fieldwork and interviews with youth and service providers in Greater Vancouver, and a series of focus groups conducted in Vancouver, Kelowna, and Prince George. Across these settings, our research has revealed that youth's ideas about what their futures should look like after treatment powerfully shapes their decision-making around when to enter treatment, what kind of treatment to consider, and how long to engage in treatment. Our youth participants were deeply entrenched in poverty, homelessness, and unstable housing and drug use, and yet they often envisioned a more normal life as being right around the corner. Here, Jake talks about having a family, a house, and traveling, and this was common. Treatment was usually envisioned by youth as one step towards these more normal lives. It was not generally envisioned as a longer-term process. Youth often put off treatment in order to prioritize longer-term plans. Here, for example, Ben talks about putting income generation first. Youth regularly highlighted the importance of social and structural supports as a part of substance use treatment services and systems. They wanted help with housing, income generation, and repairing or improving tumultuous romantic relationships, for example. A small number of youth did understand OAT as being central to their efforts at building a more normal life. However, most youth in our studies did not envision pharmacotherapies as being central to pursuing the futures they wanted for themselves. A number of youth told us that longer-term adherence to OAT did not fit with their understanding of what should happen next after treatment. Other youth understood pharmacotherapies as a quick fix only. It's clear that youth's understandings of the appropriate timelines of pharmacotherapies could be dramatically at odds with best practice guidelines. Some youth described avoiding service settings where they thought pharmacotherapies would be the primary focus of care. For example, Brooke and Holly told us that they preferred to use cannabis to manage things on their own rather than go to a detox center. When pharmacotherapies were provided in the absence of social and structural supports, young people could conclude that these medications were irrelevant or even counterproductive to the futures they were envisioning for themselves. So what does this mean for service providers? Clearly, it's not possible to completely rebuild youth's lives while they're attending a residential program or during a short stay in the hospital or during a single appointment. One approach that one of our provider participants described was referring to OAT as just one tool that might work well with other kinds of planning and actions that youth are deeply committed to, such as looking for work or going back to school. The providers we interviewed also described finding greater success by talking to youth about OAT on shorter timelines, at least initially. Starting with these shorter timelines and moving on from there means that we are working with many young people's own understandings and not against them. We have a few published papers that go into much more detail on all of this than I've been able to provide here, and we hope to produce a very concise at-a-glance style report based on our work with youth from across BC by this summer, so please do keep in touch. Ultimately, being aware of how youth are thinking about treatment, pharmacotherapies, and their futures can help providers open up more productive conversations with them about how particular treatment modalities, including OAT and psychopharmaceuticals, might support young people's broader goals. I want to take my last few seconds here to acknowledge the youth who contributed to this research who have died from overdose. We miss them, we remember them, and we continue to acknowledge their contributions to this work. Thank you also to every frontline provider who is listening right now. Truly, thank you.
Thank you so much, Danya, for such an interesting presentation. We'll now be moving into about 5 or so minutes for our question and answer period. So please send any questions you have for Danya on Slido, and I'll read them out as they're coming in. And to start it off, I have a quick question for you. And that is, I thought it was really interesting that you mentioned that young people don't really see pharmacotherapies as being central to their treatment. And do you think that stigma kind of plays a role in that?
Actually, that's not what we heard from young people. We actually heard from young people that they were connecting, especially in the Vancouver setting, they were connecting with providers and they were connecting with pharmacotherapy. So this is not an issue of access, which is where I think stigma can sometimes come in, where young people are avoiding certain kinds of settings because of stigma. We actually documented a high level of access among youth, especially in Vancouver. Things are different in Kelowna and Prince George, but even there, youth were not talking about barriers to agonist therapies. They were actually talking more about how those therapies and pharmacotherapies in general didn't fit with the ways that they understood their futures. So they weren't picturing a future where they were on OAT for long periods of time. They weren't picturing a future necessarily where they were on different kinds of psychopharmaceuticals indefinitely. So I'm not sure about the role of stigma here in terms of being a sort of primary driver.
Right. That's really interesting. Thank you still for that insight. And we have another question coming in, which is, once on Suboxone, does a youth slowly come off the medication, and how long does that usually take?
So what we documented, and I want to say here, I want to emphasize again, our research is with young people who are significantly entrenched in homelessness and unstable housing and very intensive forms of drug use, often with concurrent mental health issues. We're talking about a population in terms of our own research who falls off Suboxone very, very quickly once they got on it. So we documented just again and again and again. We would ask young people to tell us about what we referred to as their treatment trajectories, and they would talk about going on and off Suboxone and other forms of OAT at what I would describe as a dizzying rate. It was unbelievable how many times they'd gone on and off in some cases. So we did not talk to that many youth comparatively who were having success staying on Suboxone and other forms of OAT over the long term. There were some youth who were having more success with methadone and Cadian for all sorts of reasons that are covered in our published work that I won't spend too much time getting into here. But in terms of Suboxone, what we saw was that youth were falling off of it incredibly quickly. And I'm sure that fits with the clinical experience of many people who are working with this population as well.
Thank you so much for that answer. And we have time for one last question, and that is that it sounds like youth are less interested in seeking pharmacotherapy because they think it's not as productive to their future goals. Were youth mainly identifying the need for counseling or therapy as their primary treatment?
We're still unpacking our findings around counseling and therapy. It's really complicated. Some young people absolutely want more access to counseling and therapy. I think what's really important to take from our findings is that young people want help, which could include counseling and therapy, with finding housing, reconnecting with school, gaining employment or, sort of apprenticeship opportunities, things like that. They want help with building these futures. Now, I think counseling and therapy can be a very important piece of that, but we would do well, I think, to link that in with these really sort of concrete, okay, how are we building your life from here? And that's what we're suggesting with OAT as well, is that we really link it to youth's longer term plans and goals. I think that's where we'll have a lot of success. So counseling and therapy is certainly a part of that.
Great. Thank you so much for answering those questions. And that brings us to the end of this question period.